Hello, my name is Ashley Simmons, and I will be talking to you today about sepsis. So first, what is sepsis? Sepsis is an organ dysfunction caused by our body's uncontrolled response to an infection. And these infections can be caused by bacteria, fungal, parasitic, as well as viruses. Normally in our body's inflammatory response mechanism is helpful. It's very beneficial in warding off infections and sicknesses. But in sepsis, it is very amplified. It's out of control, going way overboard. It's trying to be helpful even though it's doing us harm. And our bodies thrive on homeostatic environment. We like that golden mean. So sepsis is a life-threatening condition and needs immediate medical intervention. So why is it important for us as providers to be knowledgeable about sepsis? Well, the CDC reports that 80% of patients who are diagnosed with sepsis actually experience onset of symptoms outside of a medical facility. And when we talk later about interventions, you'll remember back that it's very important that we catch this stuff early. So if these patients are coming to us and they've already been symptomatic for some time, they're really going to need us to be able to identify and be knowledgeable in the diagnostic criteria of sepsis so that we can get them the best outcome. They also found that 7 out of 10 patients diagnosed with sepsis actually had been visiting medical facilities more recently, and a lot of that contributed from them having chronic other or comorbidities that required them to visit medical facilities more often than those that are their healthier counterparts. Dantes and Epstein found in 2018 that there's 1.7 million cases of adult sepsis in the United States annually, and that contributes to 265,000 deaths a year. And again, when we talk about interventions and the pathophysiology of this, sepsis is something that if we catch early, we can intervene and we can decrease that mortality rate. So we really could benefit from having a better health promotion of what sepsis is. Meet Mr. Sep. So EMS was dispatched to a home for sickness. Upon their arrival, all the patient complained of was lower back pain. Squad call to the emergency room was as follows. En route to your facility with a 65-year-old male, complaints of back pain. Vital signs are blood pressure over 95 over 52, heart rate of 108, oxygen of 94% on 4 liters nasal cannula. We have IV access to an 18 gauge to the right AC with 1 liter of normal saline bolus, ETA of 5 to 7 minutes. Nursing staff then prepares for a patient with back pain to arrive. Excuse me. Across the room, initial assessment. The nurse looks over and we see patient's left arm is hanging off the stretcher. Oxygen, yes, it's intact, but he's still labored breathing and he's not responding or interacting with EMS staff. And that's a sign that this is going to be a little bit more of a critical case than just back pain. Hands-on assessment when we get him in the room and onto the bed. He is responsive to a sternal rub only. And when he talks, his speech is somewhat understandable, but mostly unintelligible. He's got a decline in his oxygen saturation, so we then move him from nasal cannula to a non-rebreather at 15 liters. His pupils are dilated and sluggish, and he presents with a very large left leg that is red, firm, hot to the touch, and very, very swollen, especially when you look at his right leg. Looks that it could be chronic, but there are some definite signs of infection going on. Etiology of sepsis. The most common sites, GU tract, gastrointestinal, the lungs, and skin, as well as your soft tissues. Most common illnesses associated with sepsis is going to be your pneumonias. That's the main one. Cellulitis, as well as UTIs and some E. coli. Prevalence, this was another study that I had found that went along with what we had talked about earlier as far as comorbidities. And you can see here out of 300 patients who had been diagnosed and treated for sepsis, 97% of them had at least one comorbidity. And it goes from diabetes to cardiovascular disease, which covers all of your CHF and your CAD, your chronic kidney disease, COPD as well. And that's another obvious one, just considering the issues, respiratory issues that those patients have to deal with. Clinical manifestations of sepsis, you're going to see tachycardia, and not your normal, greater than 100. It's going to be around 90 or above. And those are some of the diagnostic criteria that we'll talk about in a little bit. Shortness of breath. They're going to have a difficult time getting that deep breath in. They're going to have rapid breathing. Decreased urinary output, which we'll talk about later. Fever or hypothermia. So they're going to have a high temp or a very low temp. Chills, sweats, clammy, and a decreased blood pressure. Let's look just a little deeper, okay? So infections cause cellular damage. When our cells are damaged, our inflammatory response is triggered. Cytokines, tumor necrosis factor, all of those inflammatory mediators are going to continue going and going. But in sepsis, they're not going to stop. Then we're looking at endothelial damage, which is going to start off the coagulation cascade. And again, this is another cascade that's usually very beneficial when we're trying to fight off injuries or diseases. But with sepsis, again, this is amplified. And we're talking about platelets being used up, platelet activating factor used up, red blood cells, your fibrin, they're all going to cause these microclots. And when we talk about platelet activating factor, one of the severe outcomes of sepsis, it can be DIC, and that stems from not having any platelet activating factors anymore because we've used them all. Decreased perfusion, this is very important. If we have low blood pressure, our body's not being perfused, our organs aren't being perfused, and if we've got cells dying, then we have tissues dying, then we have organs dying, and we don't want that. Diagnostic criteria, again, temperature greater than 100.5, less than 96.8. We're looking at rapid heart rates greater than 90, a high respiration rate. Let's talk about labs. White blood cells. We're looking at greater than 12,000, less than 4,000. Your procalcitonin is going to be elevated creatinine, low platelets like we just talked about. Blood cultures. This is going to be a diagnostic criteria. We want to pull these before we start antibiotics, but this is going to be one of those things where we're going to start intervening before we get a result from this test because blood cultures do take several days to grow. In lactic acid, this is a very big indicator because when we're looking at lactic acid, we're looking at a level for greater than 2 as an indicator. And that's going to occur when our bodies are deprived of oxygen. Our normal metabolic method is using oxygen. And over time, if we're deprived of that, our body's initial response is going to be to compensate. And the way that it does that is it switches over to anaerobic, to where it doesn't need that oxygen to metabolize things. And that's where we get our lactic acid from. Treatment and interventions. This patient needed a central line access. We ended up being able to put 2 large bore IVs in him prior to getting him up to the unit. His blood pressure was corrected, by the fluid boluses. However, he was on the verge of needing dialysis, so we really just bolused him with 2 liters and not continuous infusion. They're gonna need fluid resuscitation to build that volume back up. Broad spectrum antibiotics is going to be very important. That's going to be an intervention that we want to get in them very quickly so that they have a better outcome. Vasopressors, luckily Mr. Sepp's blood pressure again maintains at a good, comfortable level. Some patients are going to decline much faster and they're going to need that help from the medicine to keep their blood pressure up. And we're looking for a MAP of greater than 65. That's our goal. That's given us a good indicator of how well our body is being perfused. BiPAP. Mr. Sepp went on BiPAP as a last-ditch effort to keep from having to intubate him. So that's something that you'll see, and that's BiPAP is good because it fluctuates. The pressures fluctuate with the way that the patient breathes in inspiration and expiration. And time matters. With sepsis, very quickly can turn the other way. It very quickly can turn into septic shock. Then you're looking at an extremely low blood pressure where you will absolutely need those vasopressors to bring that patient back up to a normal level. Then you're talking multiple organ dysfunction, and that leads to death. And that's something that we want to try to prevent. Mr. Sepp went up to the unit. He is probably still there. Hopefully he will have a good outcome and they will be able to get him back home soon. This is a picture that I found whenever I was looking at the different aspects of patients who are diagnosed with sepsis, and one area that I never really considered was the mental health aspect. This picture was watercolors, and it was done in Germany, and the artist, florist, wanted individuals to be aware of the different things that a patient with sepsis experiences. And this was it just was a very good picture and depiction of the different emotions that one can experience. Several articles that I found talked about how the mechanism of septic shock can actually be like a psychiatric break in a patient, and that it is not uncommon for individuals who are diagnosed with sepsis and recover to experience post-traumatic stress disorders such as depression and anxiety. And that is all that I have for you today. Excuse me. Hopefully I helped you have a better understanding of what sepsis is better today than you had yesterday. So thanks for watching.